Thank you for that introduction. Hi, everyone. My name is Morgan. Today, I am presenting on my project that is titled, can you guys hear me, by the way? Should have checked. Perfect. This is on my project that is titled Anatomic Variations in the Origin of the Superior and Inferior Vesical Arteries, a Cadaveric Study. So let's hop into it. So just to kind of get everyone on the same page, here's a little introduction. The superior and inferior vesical arteries are essential components of the vascular supply to the bladder. The superior vesical artery, also known as the SVA, and the inferior vesical artery, also known as the IVA, are branches of the anterior division of the internal iliac artery. And the IVA is traditionally considered to be predominantly in males. Some texts state that the IVA is only present in males, and others state that it is replaced by the vaginal artery in females, which can have accessory branches supplying the bladder. Current literature is contradictory and pretty unclear. It's important to recognize that significant anatomic variations exist in both the origin and branching patterns, especially between males and females. This cadaveric study examined those variations in order to enhance the understanding of pelvic vasculature and its clinical implications. So for this study, we went in to examine the pelvis of donors from both the Joplin and the KCU campus. We excluded donors that had vascular damage, and this was all done after the first years had dissected. So there were definitely some donors that we had to exclude from this due to damage. But we isolated the internal iliac artery and then dissected it to reveal its terminal branches. The inferior and superior vesical arteries were traced to their insertions on the bladder. And the data recorded includes branches, artery origin, cadaver sex, and laterality. Here is a little picture that is from a radiology journal that kind of gives you the typical textbook anatomy of the both anterior and posterior divisions of the internal iliac. And then here you can see the superior vesicle is kind of more toward the distal end and is branching off right before the obliterated umbilical artery. And then we have the vaginal for females and inferior vesicle for males, as it's termed in most literature. So let's get into the results. Superior vesical artery was a little bit boring. We had 28 total cadavers between the campuses, which is a pretty small sample size, but it was enough to use for statistics. And we identified 42 superior vesical arteries among 18 females and 10 males, and the rest were excluded due to damaged vasculature. 95% across the board between genders or sexes were branching off of the proximal pain portion of the umbilical artery. And we had one male donor who had two branches that originated more proximal off of the anterior division of the internal iliac artery. So that was to be expected. And then moving on into the inferior vesical artery results, we have the differentiation between sex. So 18 female cadavers, we had 72% of the donors with a present inferior vesical artery. And then 10 male cadavers showed 90% presence of the inferior vesical artery. The IVA obviously had a little bit more variability, and that's known in literature as well. And the results for the origin arteries were a little bit shocking. So let's get into that. So for textbook anatomy for males, it's mostly said in the text that it branches off of the anterior division of the internal iliac artery. And in my investigations, 50% came off of the proximal umbilical artery, and the other 50% came off the internal iliac artery. So that was a bit surprising, just because we had learned, not that. We had learned that it was pretty straight across the board, branching off the internal iliac artery. So that was a bit of a surprise for the male donors. And then going on to the female donors, we saw a lot more variability. We did have one outlier donor that had 6 branches coming off of the vaginal artery, and that is included in the first part. So we had 25.9% off the proximal umbilical, 7.4% off the internal iliac, 48 off the vaginal, including that outlier donor with 6 branches, and then 18.5% off the uterine artery. And then removing that data kind of leveled everything out a little bit, the outlier data, and that made everything to be about 33% from the proximal umbilical artery, 33% from the vaginal artery, and then 24% from the uterine artery, and finally 10% from the internal iliac. And then here is just a visual with charts showing on the left the including the donor with the 6 branches. And then on the right, we excluded the donor with the 6 branches just to kind of give you a better idea of what was actually going on. So you can take a look at that there. And then for stats, we did a independent sample t-test, which revealed that there was no statistical significant difference in the presence of IVA between males and females with a p-value of 0.289%. So that was kind of what we were looking to see. I guess we were kind of trying to see if there was a statistically significant difference between males and females having an inferior vesical artery. And the findings challenge the information that the IVA is only present in males and supports the presence of inferior vesical arteries in females. So that was kind of cool. And so why is this important? I mean, every project that we do is kind of geared toward, clinical relevance and the clinical implications. So having knowledge of these variations is crucial for urologic and gynecologic procedures, as well as interventional radiology procedures. So things like hysterectomies, bladder cancer resection, management of hematuria, pelvic exploratory surgery, pelvic floor reconstruction, urinary incontinence, pelvic trauma, all that kind of stuff, and so many more procedures. This is pretty relevant for. And then kind of bring everything together clinically, we can talk about how there's a longstanding belief that the IVA is exclusive to males, but the findings obviously align with a recent research study, which I have linked in my references. There was a recent research study indicating that it is present in females as well. So this kind of aligns with that research as well. And it emphasizes the importance of recognizing those vessels in females. And then, pelvic vasculature, like I mentioned, has implications when there's variations. So pelvic surgeries with unanticipated vascular patterns can increase the risk of hemodynamic complications, which is obviously not ideal. A major concern is potential devascularization of the bladder, and that is something that is more at risk in surgeries involving pelvic vasculature, but more common in pelvic or in bladder reconstruction, tumor resection, and hysterectomies. And so in my research, I was kind of looking into which procedures for both males and females were most commonly associated with vascular risk. And so I came to the conclusion of like hysterectomies and prostatectomies were the most kind of risky procedures for people with vascular variations in the IVA. And just kind of some background, uterine artery ligation in hysterectomies is pretty much up to the provider, but in cases when there is complex anatomy or variations in vascular supply, it's recommended to ligate the uterine artery at its origin off of the internal iliac. And obviously, if you have branches supplying the inferior bladder from that uterine artery, which is about 30% of women based on this study, that could have implications in bladder vasculature. And then kind of going on the same track with males, the IVA is a major supply to the prostate and vas deferens. The middle rectal artery, I believe, also supplies some accessory supply as well, but inadvertent devascularization of the IVA in males can have significant implications on urinary and sexual health in males. So that's definitely a consideration in prostatectomies. So these findings also have implications in interventional radiology. So people who have like pelvic trauma, postpartum hemorrhage, and intractable hematuria will often be consulted by interventional radiology, and they will sometimes embolize with interventional techniques. So having knowledge of these variations is kind of, important and can be helpful for that as well. And then tying this all together, wrapping it up, the findings contribute to the growing base of anatomic knowledge and hold clinical significance in pelvic surgeries and interventional radiologic practices, as well as our medical education. Current literature may not be an accurate representation of vascular supply to the inferior bladder, so that's something that can be, hashed out a bit more and researched more, and this is definitely a good start for this project. Further research is recommended, with larger sample sizes, obviously, and it's recommended to evaluate the prevalence and clinical implications for these variations. And then here are my references, and that's all.